Hello and welcome everyone. Today's journal review is Ceftriaxone to prevent early ventilator-associated pneumonia in patients with acute brain injury, a randomized control trial. This trial was published in January in Lancet Respiratory Medicine. So, what was the research question? It was, can a single early administration of Ceftriaxone 2 grams to patients with acute brain injury prevent early VAP and improve the related outcomes? So, what was the lacuna in the current literature for which they decided to do this trial? The existing studies on preventing early VAP patients lack robustness due to non randomization, lack of blinding, and limited generalizability. Now, previous research has suggested shorter antibiotic administration to reduce early VAP and antibiotic resistance in acute brain injury, but there is little scientific evidence supporting such a recommendation. The studies conducted so far are limited by single center focus, performance in specific population, that is cardiac arrest, and lack of demonstrating benefit on length of stay or mortality. There is a significant variability in the incidence of early VAP reported in severe trauma and stroke, indicating a gap in understanding the risk factors and effective prevention strategies. The impact of early VAP on neurological outcome in patients with brain injury remains a poorly documented and understood concept. So based on all this, they have planned this study. So let's see which aspects of these they are able to overcome and which will still remain after we do the post analysis. So coming to the methods, the study design was a multicentric randomized double-blind placebo-controlled assessor masked superiority trial. It was 9 ICUs across 8 French university hospitals. They got their approval from their institutional review board and they registered it in the clinicaltrials.gov. The participants were adult more than 18 years, both sexes, any ethnicity, who had a GCS of 12 or less, and who are predicted to need a ventilator for more than 48 hours after head trauma, stroke, subarachnoid hemorrhage, and they were considered to be eligible. So, what were the exclusion criteria? That was coma due to tumor, infectious disease, or cardiac arrest. So, these are the cases where we cannot implement the findings of this trial. So, high risk of death within 48 hours, ongoing antibiotic treatment, hospitalization in the past month, expected need for antibiotic prophylaxis within the 24 hours of post randomization, nasal route of intubation, subglottic suction present, mechanical ventilation via tracheostomy, contraindication or allergy to beta lactams, participation in any other research, and patient or family refusal, patient under legal or administrative restricted freedom. So how was the randomization done? Patients were assigned to the group 1:1 by a secure web-based system ensuring unbiased distribution. Randomization was stratified by the patient center and the severity of the unconsciousness at inclusion based on the GCS, that is less than 8 or more than 8, to address the variations in the patient treatment and the increased risk of VAP in more severely unconscious patients. A computer generated sequence was created by the statistician not involved in the recruitment process, utilizing variable block sizes to maintain the unpredictability of the randomization. The study maintained a double-blinded approach where patients, healthcare providers, assessors, and the study statisticians were unaware of the allocation group to prevent bias in the treatment and assessment. The intervention. The enrolled patients in the intervention group received a single 30 minutes intravenous dose of 2 grams ceftriaxone and in the placebo group of normal saline. To ensure that the treatment remained blinded, special vials labeled with the study trial name containing either zone or sodium chloride were used. Now, patients were prepared by the nurse from a different unit not involved in the patient care using opaque syringes and infusion lines to hide the different colored solution of the ceftriaxone. Now, what were the other standard prevention used for VAP? These were hand washing, head and elevation, use of heat and moist exchangers, monitoring tracheal cuff pressure, sterile tracheal suctioning, mouth care, no systemic respiratory circuit changes, preferential oral insertion of feeding tube, early enteral feeding, regular blood sugar monitoring, ulcer prevention, and prompt tracheal extubation. And SDD and SOD was not performed in any of these patients. However, these were the suggested intervention strategies, but not necessarily was done in the all center. Each center had their own protocols. Now, VAP assessment was done by the ICU physician multiple times a day until day 28, employing the CPIS, chest radiography, and the microbiological parameters. To start a new antibiotic was deferred until the assessment was made. Confirmation of VAP was based on the ATS criteria, and patient needs to meet all the three criteria for to get a confirm of VAP. But that doesn't mean that they were not getting the treatment. To be taken as a VAP in the study, it has to be confirmed by all the three criterias. Now, they had a central adjudicating committee consisting two senior intensivists who were blind to the assignment, and they anonymously checked the patient's data and classified a case as VAP or non-VAP. And if there was a dispute among them, a third intensivist decision was considered to be final. Now, other infections were managed as per local and national guidelines. Uh, 4 swabs were taken from the rectus on admission and at discharge to look for resistant organisms. Now, what were the signs looking for the VAP? The clinical signs, that is the fever, increased secretions, or WBC changes. In radiology, they look for infiltration, consolidation, cavitation, or effusions. And in microbiology, they look for positive cultures based on the various sampling techniques. The colony count was used as a cutoff. Regarding the outcome, the primary outcome was the proportion of patients who developed early VAP from day 2 to day 7. And the secondary outcomes, that is on day 28, where again VAP, which can be late VAP or early VAP or anything, type of organisms, exposure metrics like ventilator free days, antibiotic free days, ventilator associated events based on CDC, VAP incidence based on ATS and CDC definitions, time for inclusion to the first spontaneous ventilation test, proportion of patients who had the resistant organisms, neurological outcome, mortality and safety parameters. And they had also secondary outcomes by day 60, which were exposure to ICU and hospital, indicating number of ICU and hospital free days, neurological outcome, and mortality rates. In the statistical analysis, first they did the sample size calculation, expecting 30% incidence of early VAP and a 15% reduction of the intervention. And with 90% power and 5% alpha error, they found a study population which was around 354. And the rest was intention to treat analysis. Because there were a competing risk of mortality and VAP as competing parameters, they used the fine gray model for the stratification, and this was done because of the competing parameters. The standard protocol for presentation has been used, and the event free days, that is a date until day 28 to day 60, was set to 0 if the patient died in between. And comparison between the event-free days was performed by the Mann-Whitney's U-test. Data management was overseen by a research monitoring officer, and pharmacovigilance looked after the drug toxicity. Missing data was not imputed and was interpreted as it is. So coming to the results, 2,230 patients were analyzed. Out of this, 1,885 were excluded. That's a very large amount, mostly because they were having some indication for receiving antibiotics prior also, or they were ventilated for more than 12 hours before inclusion. So almost 1,000 patients were excluded thus, and only 345 were randomly assigned out of the 2,230. That's a very large amount, which makes the generalizability a question. So next is the 171 were allocated to the Ceftriaxone, 174 to the placebo, and finally these were the numbers which were analyzed. So coming to the baseline differences, mostly it was similar between the two groups, not much difference in all of the criterias. However, if you look at the primary outcome, they found exactly what they were setting out to do, that is a 32% incidence of early VAP in the placebo, while 14% in the Ceftriaxone. So there was a 18-point difference in the absolute reduction. So this was consistent along all the other parameters as well, though the neurological outcomes remained essentially the same, while the mortality rates were better with the Ceftriaxone group. The secondary outcomes were again roughly similar, but mortality was continued to be more in the placebo group probably due to the infection. Hospital free days, ICU free days, all were sufficiently large, showing significant clinical benefits of using the ceftriaxone and prevention of the VAP. So this is the diagram showing the difference between the VAP rates. This is the early VAP and this is the overall VAP. And you can see here the placebo has an increased incidence of VAP. And these are the resistant organisms which were not much in the intervention group. So you can say that the use of ceftriaxone did not result in much incidence of negative gram negative uh, resistant organisms. However, the study has some of the limitations. That is, the VAP prevention module was obviously not something which could be controlled by the treating group, and the digestive microbiota monitoring was not really done, which could have had an impact on the VAP incidence. The impact of other healthcare associated infection could be there. Blinding of the procedure, that is, it could have been better if the pharmacy was doing it rather than the nurses, because nurse is essentially a part of the treating team only. And the adjudicating committee again was the part of the overall ICU team, and it was not really an independent body as such. However, based on the overall evidence, we can conclude safely that the use of ceftriaxone single dose does reduce the risk of VAP, and it has multiple clinical benefits also in terms of reduction in the mortality rates as well as the hospital days and the ICU days. However, the generalizability of this information remains to be seen, but if your patient is having head trauma or stroke, you can give one dose of ceftriaxone and hope that the reduction is there in the incidence of early VAP. Thank you for your patience.